But let me introduce today's speaker, Professor Gronchi from Milano, Italy, and he has established there a world-class sarcoma center over the last 2 decades. He's very active internationally in many organizations and collaborations. Among these, he's a motor of the important transatlantic isolation Retroperitoneal sarcoma working group, about which he's talking today too. Professor Gronchi is one of the outstanding sarcoma experts and opinion leaders of our time, and thereby influencing the lives of many of our patients. It is therefore with great pleasure that you are sharing today your experience on retroperitoneal sarcoma with us today. Please, Alessandro.
So, first of all, thank you very much. Bruno, it's a pleasure for me to be here and with your group. We had the chance to meet in the past months a few times to establish this collaboration, which I am very happy of. I'm just sorry that we cannot do these kind of things in person, so we need to live with these virtual systems, which are in a way good because they allow you to basically perform many probably more events than what you can do in person, but of course you miss the chance to physically see people and discuss also offline, not just about stuff that I'm going to talk today. But we need to do what we can. So I'll discuss this topic without the chance of hugging you at the end. But it is what it is. So now we'll be discussing the topic of retroperitoneal sarcoma from 3 angles, basically. Let me just advance. Okay. Yes, so you know that retroperitoneal soft tissue sarcoma originate different sides of the body, and the retroperitoneum is one of them. Basically account for 10% of all retroperitoneal sarcoma. The majority occur in the extremity and trunk wall, but the retroperitoneal site is one of the other important location where this tumor can arise and present specific challenge. So number one, how we diagnose retroperitoneal soft tissue sarcoma. There has been a lot of discussion over especially non-expert centers, whether performing a preoperative biopsy is safe and should be done or not. And a number of studies that have been recently performed clearly show that performing retroperitoneal biopsies for retroperitoneal masses is safe. So the risk of seeding does not exceed 0.37%. So it's far more risky to undertake an operation without knowing which is the final diagnosis than performing a preoperative biopsy to establish diagnosis and make the strategy and then do the surgery. Also because there are a lot of differential in the retroperitoneum among the possible masses that you may have. This is an example of what is in fact an Hodgkin lymphoma. You should not undergo any surgery. It may be easy to assess this in expert centers, but in other centers it may not. And I have seen cases that have been referred after a tentative resection of what turned out to be a non-Hodgkin lymphoma. So while in this case, maybe nobody would try to resect this mass because there is an encasement of the major vessel, everybody will try to resect this mass on the left-hand panel. But if you resected it, you would make a big mistake because also this was an Hodgkin lymphoma, which resembles a leiomyosarcoma, but in fact it is not. So it's important to know in advance what we are doing because you may make big mistakes. This is the same here of another type of masses where you have a differentiated liposarcoma, which doesn't really look at the differentiated liposarcoma, in fact is. On the left side, on your right side, you see a germ cell tumor, a disease that needs to be treated in a completely different way. Again, at the differentials, you can see the pancreatic cancer that doesn't look like pancreatic cancer on the left side and the leiomyosarcoma on the right side. Again, germ cell tumor and leiomyosarcoma, or myelipoma of the adrenal gland, and well-differentiated liposarcoma. Angiomyolipoma, well-differentiated liposarcoma, looking very similar. So it's very important to perform a biopsy. And the risk of seeding is in the 2% range, it varies between 0.2 and 2% if in this different series, but no seeding occur if you perform a biopsy using a coaxial needle and non-transabdominal, so basically with a posterior or a lateral approach, so an extraperitoneal approach. So it's important to perform it. It's performed in experienced hands, and it is done under ultrasound or CT scan. In our experience over the past years, the use of systematic biopsy has allowed us to, even in a center where patients were referred to rule out sarcomas, to identify a 20% of cases which were not sarcomas and didn't need an immediate surgery. So speaking about surgery, what is the right surgery for retroperitoneal sarcoma? So I start by asking a question, a very simple question to the audience, and I guess there are some orthopedic oncologists here listening to me, even if they may not do retroperitoneal sarcoma, they are interested in the sarcoma disease, and they are all very well aware which kind of surgery one should perform here. Not a simple excision like this, but a wide excision like this, where basically the tumor is removed and blocked with surrounding tissue, and at the bone level, and at the nerve level, and at the vascular level. This marking is made by its the adventitia, the perineum, and the periosteum, which are considered safe margins, even if they are closed. So an orthopedic oncologist will never give up to the idea of performing wide negative margin resection, even in a tumor where there are multiple anatomical constraints. So why in the retroperitoneal we should do any difference? So what would people resect here? What would the general surgeon would resect here? He would be tempted to resect this tumor, but in fact, he would have to resect the tumor we do for extremity. So as I said, I mean, this is a rare disease, and in Italy, expect 400 cases per year. In the past, the 10-year survival was in the range of 30%, with an expected local recurrence at 5 years, which was exceeding 50–60%. So a disease which was very biologically overall not super bad like epithelial cancer, but characterized by high risk of death. And this death was predominantly caused by local regional recurrences. So local regional recurrences used to be the leading cause of death in retroperitoneal sarcoma. Why so? Well, it is so because of the difficulty in performing a complete resection or a negative margin resection, as I was saying, mostly because it was treated differently. It was treated in centers where surgeons were not very much aware of what sarcoma is, and were tempted to perform more conservative procedures just because the way retroperitoneal sarcoma usually grows doesn't push the surgeon to perform resection of the surrounding organs, just because this seems to be healthy and safe. And so surgeons were tempted to just remove massive, simple excisions. But can we apply the same principle that we apply in extended superficial sarcoma also in the retroperitoneal? So trying to perform even at that level a negative margin resection, or what is supposed to be the closest thing to a negative margin resection? The answer is yes, even if it's a therapeutic challenge, because these tumors tend to present late, because the anatomical location is complex, and there are close relations with multiple vital structures, and this close relation impacts the ability to perform a wide negative margin resection. However, we basically developed with CD Bourgogne in France the idea that this surgery should have been extended rather than limited to the tumor, extended to the surrounding viscera as much as possible in order to try to perform, to translate into the retroperitoneal the same approach we are using in the extremity. So a wide approach. So this is a complex but now very much reproducible procedures that can be performed in 6 stages. I don't want to go into details about this, but it's a complex procedure that everybody now has learned to do well, and needs that multiple surgical skills. Surgeons need to be able to perform gastrointestinal surgery, epithelial pancreatic surgery, vascular surgery, urologic surgery, GYN surgery, and some orthopedic surgery as well. A single surgeon doesn't have all the skills. It needs to be able to orchestrate different surgeons that have different skills and work together to perform the best surgery possible for the individual patient. So we actually show in Milan and in Paris how this approach improved the local control rate over the years, and also this translates into a survival benefit. Of note, when people discuss whether this approach was worthy or not, they were not aware of which was the real organ invasion rate, even after resecting organs which were macroscopically uninvolved. The microscopic invasion rate was in the 60%. And there was also a mouse model study that was performed in the 90s by a Israeli group that showed that simply when they were implanting fibrosarcoma in the perineal fat, removing just the tumor was associated to a high risk of local recurrence and death of the mouse, while if you perform the resection of the nodule of the fibrosarcoma in the perineal fat with nephrectomy, the survival and the local control was far better. We also compare the outcome of patients treated in a reference center with the upper population, the series is showing a large difference. So which is the outcome of this patient today by performing an optimal surgery? The 5-year local control rate is not 50-60%, local recurrent risk is not 50-60% as it was in the past, it's now 20%, so it's basically half of it. And the overall survival at 10 years has moved from 30 to 50%. So it doesn't mean that surgery does all. It means that there's improved by 20% the outcome of these patients. And when we looked at our series over the past years to see whether there was any further improvement over the years at our institution, what we saw was that we were able to improve survival, probably because we improved the perioperative care of this patient, we improved the way we were treating them, but we could not improve further the local control, because it was 20% in the first period and is now 18% of the recurrence risk at 5 years. So it's still an important achievement, because when you compare these results of our series, especially in the histology subtype like well-differentiated, like liposarcoma, which are the histologies, as I will be discussing in a minute, which recur the most, with those of other series where there was a more conservative approach, the local recurrent risk is far low. So basically, there's an 18% local recurrent risk for well-differentiated liposarcoma at 5 years, against the 40% local recurrent risk at 5 years in well-different liposarcoma, and the 40% in deadly fibro against the 60% deadly fibro. We discuss here that this comparison is not, perfect, because the case mix may be different, but we're basically comparing the outcome of two large institutions where the case mix is not basically so different, and two different approaches may translate into clear different control rates. So when we looked at the improvement over time at the single institution based on the histology subtype, what we showed was that we were not able to improve further the outcome of liposarcoma just by improving surgery, so we could not improve it any further. When we look at intermediate differentiated liposarcoma, what we saw was that there was a drop in the recurrent risk from 45% to 23%, and this is because we started using, and we'll be discussing this later, more radiotherapy, more and more radiotherapy. It's not just a surgical thing, without any differences in distal metastasis. And in high-grade differentiated liposarcoma, what we changed was a systemic approach. We decided to use a lot more chemotherapy in the recent years, and this may have translated into a lower risk for distal metastasis. And also about this, we'll be discussing later. So there are some histology-specific considerations to make when we discuss retroperitoneal sarcoma. So we mentioned how important it is to perform the proper surgery and extended procedure, because this translated into better survival and a better local control. But how does this apply to the different histological types? This is not a single disease. There are at least three major diseases. So liposarcoma, which is subdivided into the well-differentiated subgroup, the intermediate grade dedifferentiated subgroup, and the high-grade dedifferentiated subgroup. Leiomyosarcoma, solitary fibrous tumors, and a number of other histological types that deserve individual consideration that I will not mention today. I will focus on these basically three histological types. So in liposarcoma, the risk is predominantly local. That's why it's so important to perform the widest resection possible. The risk is local. And the risk is local because the pattern of growth of liposarcoma is different from that of all other retroperitoneal sarcoma. Number one, because it tends to spread through the retroperitoneal fat to the root of the mesentery and into the contralateral retroperitoneal space. Number two, because the well-differentiated component of the liposarcoma is pretty much undistinguishable from normal fat. So if you don't clear all the fat out from the retroperitoneal space from which the tumor originates, you will always risk to leave behind the well-differentiated component of your tumor. And therefore, the only way to clear all the fat out is to take the tumor out with some of the organs that lies in that retroperitoneal. Most of the time, these organs are in fact the kidney and the colon, and part of the psoas muscle, which lies behind. In leiomyosarcoma, the situation is different because leiomyosarcoma, the retroperitoneal, tend to have much better definition of its margins. They don't have the problem of the clearing of the retroperitoneal fat out in order to perform the operation, and often they originate from vessels, most often from the vena cava, but also from the renal vessel, the iliac vessel, and gonadal vessel. Actually, not all of them, but most of them originate from vessels. And surgery can be performed without giving up the idea of performing a negative margin resection, but preserving some of the organs. In this case, for example, of leiomyosarcoma of the vena cava, what we preserved was the kidney and the ureter without giving up to the idea of performing a negative margin resection, which this turned out to be. Another example of leiomyosarcoma of the vena cava, which represents basically 40% of all leiomyosarcoma of the retroperitoneal. These are the sections that are usually interested, but just to say that most of these retroperitoneal leiomyosarcoma originate from vessel. This is a renal vein leiomyosarcoma, this is a iliac vein leiomyosarcoma, this is a gonadal vein leiomyosarcoma. So if you look for the vessels, you find the vessels that probably are the cause of the origin of your tumor. This may not be true in the pelvis, and even when we exclude, of course, uterine leiomyosarcoma, which are different, it's a completely different story. But yes, it's a disease that mostly originate from vessels. Solitary fibrous tumors is also a tumor that tends to be very well defined and has a very indolent course. So in a tumor like this on the left side, that is a solitary fibrous tumor, the approach is completely different from down on the right, which is a well-differentiated liposarcoma with all these well-differentiated components. So it's not only this, but it's all this. And most of the time, inexperienced surgeons would just take out this, leaving the well-differentiated component behind. Now, it's one more reason to know what you are dealing with is that in a situation like this, if this were a dedifferentiated liposarcoma with a well-differentiated component all around the kidney, you would perform a different operation that you perform knowing that this is a solitary fibrous tumor. Here, knowing that this is a dedifferentiated component of a liposarcoma, you perform an operation which is different from the one you would perform if this were another histology subtype. So, this is what you do in a solitary fibrous tumor. You present the kidney, you present the psoas, you just move it, you're surrounded by tissue, in this case, the colon and some of the fascia, the tissue behind. While in dedifferentiated liposarcoma, as I mentioned, you remove the whole retroperitoneal fat with psoas muscle, the left colon in this case, and the kidney. And you see here this specimen. So there are other histological types that I'm just going to mention. Malignant peripheral tumor of the retroperitoneal predominantly originate from the femoral nerve. This is still considered a retroperitoneal tumor, but it's a different disease, and it should be treated like we treat NPST at other sites. So you see that the muscle basically protect the tumor from, or protect the abdominal cavity from the tumor, and the tumor is contained in the muscle because it originates from the femoral nerve. And so the approach usually is totally different. You do an extraperitoneal approach, this is a patient on the side, you enter the retroperitoneal space, and you remove the whole tumor with the nerve without even considering to remove retroperitoneal organs. In addition, there are some other locations that are not purely retroperitoneal, like the intra-intrapelvic location, for example, in the pelvis, where also the histology distribution is different. The common histology types there are myosarcoma, solitary fibrous tumor, liposarcoma less common, and the pelvis is even more complicated for the number of structures that are present there. And usually you perform a more conservative procedure just because you need to put together quality of life and chance of cure. Most of the time, by the way, you consider treating these patients with preoperative treatment, and since solitary fibrous tumor is the common histologist, one can also consider preoperative radiotherapy more often than in other sites. And also, finally, sarcomas of the psoas that needs to be treated differently, and also ILT. Sorry. So ILT of the psoas should not be treated. You see that it's completely contained in the psoas mass. So this tumor should not be treated as a typical ILT of the retroperitoneal, where you would perform the surgery I described before. But in this case, being this an ILT of the psoas muscle, a simple excision can be performed as you perform simple excision in most other trunk and extremity locations. While in, for example, DPS of the psoas, the approach is completely different and requires a multimodality treatment. So given all this complexity, given the need of understanding where even the natural history of these diseases to make the right choices, the right decision, not only in terms of surgical planning, but of course also in terms of surgical planning, but and also in terms of preoperative therapies, postoperative therapies, it's so important to refer these patients at initial presentation to sarcoma specialized centers, to a sarcoma surgeon. And this is a key to improve survival. It has been well shown by several groups. We compare this, and the group which has shown this better as, of course, the French sarcoma group, where they showed how this survival is better. Even in the US, they did the comparison, and this is survival according to the number of cases per year. This is 5 per year, 10 per year, more than 10 per year. And they didn't go further than that because they are not centers that do more than 15 cases per year. Because in US, referral at the initial presentation is very, very poor. So only 10% of cases are referred at high volume centers, 90% are treated in low volume centers. In the French sarcoma group comparison, specifically addressing the outcome of retroperitoneal sarcoma patients, they found that 37% of patients were in fact treated at the reference center and extra centers, compared to 60% outside, and the outcome was clearly different, both in terms of local recurrence-free survival, progression-free survival, and overall survival. So this difference is impressive, and by doing nothing, by adding no other therapies, we improve the outcome of your patient very significantly. So it's important to have reference centers for retroperitoneal sarcoma. It is important that there are not many because they need to treat a decent number of cases in order to become expert in the field. So what about adjuvant therapies? Well, first of all, as I was mentioned, it's not all about surgery. There are other modalities like radiotherapy or chemotherapy. So let's start discussing preoperative radiotherapy. Why preoperative radiotherapy, non-postoperative radiotherapy? Because this tumor tends to grow to a very large size, and postoperative radiotherapy it's basically impossible to deliver at therapeutic dose without causing important side effects. So no matter what technique you have, no matter what beans you have, no matter what you want to use, I mean, protons, carbon ions, and IMFT, rapid arc, whatever, there is no way to perform a postoperative treatment in the right way. So postoperative radiotherapy in retroperitoneal sarcoma is a little bit different in the pelvis, but for retroperitoneal sarcoma should be banned, should not be used ever, never again. While if you want to consider radiotherapy, consider it in the preoperative setting. Which data do we do have to sustain the use of preoperative rad in retroperitoneal sarcoma? Well, the number one thing to consider is that this patient, even when operated well, they do recur. And the risk of recurrence can be predicted by using, for example, an app which is based on a phenomenon called circulator. So in a case like this, there's a 35% risk of recurrence, and you see where this risk of recurrence predominantly affect, as I mentioned, liposarcoma patients, which are these are the patients who will be dying because of local regional recurrences. So these are the patients whose local recurrence will be the leading cause of death. There have been an attempt to show retrospectively, because as of a couple of months ago, there were no randomized study reported about the use of radiotherapy at variance with what happened in extremities of sarcoma, where this study has been available since the late 90s. So, given to the lack of prospective, well-designed randomized studies, we had to rely on retrospective analysis. And this is one of the largest that was published not long ago, and which raised a lot of attention about the use of preoperative radiotherapy. It was based on the National Cancer Database in the American Cancer Database, which covers basically 70% of the cancer centers in the US. And this study basically showed an advantage in the use of radiotherapy, both preoperative or postoperative, on survival. And we're not able to look at the impact of radiotherapy on local recurrence and possibly distant metastasis, just because this information are not included in the NCDB. But this NCDB lacks a lot of information. And what was evident from the very beginning was that the predictor, so for the use of preoperative or postoperative radiotherapy were different. Usually smaller size was a predictor of the use of postoperative radiotherapy, and surgery in academic center was a predictor of the use of preoperative radiotherapy. So, we looked at this and we wrote an editorial about this, because in the absence of a randomized study, these retrospective analyses were not enough to make a recommendation. And RT was basically associated to a better outcome, also because it was a proxy of better surgery in the preoperative group or better tumor in the postoperative group. And the lack of information about disease-related events was one of the most important limitations. Again, this is another example of another retrospective study actually done by us, where in spite of a difference in outcome in univariate analysis, so in a non-match analysis, when we matched the analysis and we looked at differences in outcome, we were not able to show any difference in favor of radiotherapy. This was better designed than the previous study, but again, biased by the fact that these studies were retrospective. So the first prospective study that was designed to address this question in retroperitoneal sarcoma failed miserably, I think 15 years ago, because of poor accrual. But the study was performed in the US, and given the lack of referral, given the lack of regionalization, they were not able to recruit patients at a good pace. So at some point, the NCI, which sponsored the study, closed the study, right because of the low accrual. They were able to accrue 16 patients. So 15 years later, we decided to embark. So thanks to Sylvie Bovalo, who was critical and was like the driving force on this study, we were able to embark in this effort again. And we decided to start this in 2010, and the recruitment started in 2011, and the study were able to close in 5 years. We managed to include 266 patients. And the results of the study, the median follow-up of 33 months, 121 abdominal events, were reported very recently. The distribution of cases in this study was a little bit in favor of the inclusion of liposarcoma. And while on overall there was no difference in the abdominal recurrence-free survival, even the liposarcoma group, when we look carefully at the way we are defining the primary endpoint, which was abdominal recurrence-free survival, we decided to run a sensitivity analysis to try to understand whether the way we define this endpoint was in fact correct. I know that that's orthodoxically wise is not the best way to look at one randomized study, but given this the only randomized study, we have to take the advantage of this and to try to exploit all possible information, including it even in a less orthodox way. And so while formally the study was negative, when we looked at the way we defined the endpoint, we found that we also included progression before surgery as one of the criteria to be counted as an event, one of the events possible to be counted as this primary endpoint. And when we removed it, so when the patient, because patients who progressed on radiotherapy were in fact operated, we were able to show that in the liposarcoma group, a difference was in fact in favor of radiotherapy, was in fact there. We then did another thing to try to exploit the results of the study. We created this Strexit study. So STRAST and Strexit. What is Strexit? So what I'm going to tell you now is very new, basically, because this data will be presented at CITOS in a couple of weeks. So I trust you to look at this and know that these are a little bit confidential, but CITOS doesn't give any embargo, so it's not asked, so I can discuss this with you because I'm happy to show you some further things that are not yet published. So what we did, we decided to run in 6 of the 31 centers which entered patients into STRAST. And these 6 centers were the largest recruiter and entered basically 70% of the STRAST patients. So these 6 centers, here there's a mistake, it's not really 6, observed and treated in the same time period a total of basically 1,000 patients. Only 190 were included in the study. So we decided to use the data of the other 800 patients. So why should Strexit be different from other retrospective studies that we decided a few minutes ago? Because it is performed in exactly the same institutions which were participating in the randomized study in the exact same time interval, the same surgeon, the same techniques in a short time frame. So it's kind of a different effort as compared when you collect a large retrospective study over a large time intervals in a large number of sites. So compare the Strexit and the STRAST cohorts, you clearly see that basically while in the STRAST cohort, half patients received radiotherapy. This is obvious because this was randomized studies. Only 130 of the 831 patients in the Strexit cohort did receive radiotherapy. We basically, why they were not included if eligible, basically more than 50% of the patients not included in STRAST could have been included in STRAST. The reason why they were not included was mainly patient preference, but also surgical oncology preference, radiation oncology preference, and so on. So there were many reasons why these patients were not included. And I believe that today, every randomized study should always be run in parallel with an observational cohort where all the patients who don't make it for the study are included and information on their ARFS is collected in order to put in perspective, in the right perspective, the results of the randomized study in the years to come. So we did 2 things basically. The first thing we did was to see whether the results in the Strexit cohort were equal to the one in the STRAST cohort, and we used a propensity match tool. And when we matched the cases, we found that a pretty good matching in 262 of them, and these 262 were the basis of the comparison I'm going to talk about now. So 131 had surgery alone, and 131 had surgery and radiotherapy. And you can see that in the extensive cohort, basically the results were very similar than in the STARS cohort. Not, some difference, but not statistically significant in favor of radiotherapy in the overall cohort, with better outcome for the liposarcoma subgroup. We then decided to pool the cases in order to see whether we were able to go a little bit more in detail in the subtypes, so histological types, given the different outcome with different histological types. And again, we were not able to show any different, statistically significant difference in all histologies, while we confirmed the statistically significant difference in the liposarcoma subgroup. When we broke down the liposarcoma subgroup in the subgroup with the high risk of local recurrence, so well-differentiated liposarcoma and low intermediate grade differentiated liposarcoma, we confirmed a large difference, 15% difference of local control at the 3-year time point, which were even becoming larger at the longer time point, which was not there for the high-grade differentiated liposarcoma subgroup or the leiomyosarcoma subgroup. And I think this data make very much sense. They were confirmed also in the completing risk analysis and so on. They make a lot of sense because these are the histological type where local recurrence is the higher, is the major problem. High-grade differentiated liposarcoma do metastasize more often than recurrent locally. So while preoperative should be considered a patient with well-differentiated liposarcoma and G1, G2, G5, they should not be considered high-grade leiomyosarcoma, even if at the current follow-up, overall survival and metastatic survival are not yet impacted by preoperative. I don't believe that metastatic survival will ever be impacted by preoperative radiotherapy, but survival in this subgroup, so well-defined liposarcoma, G1, G2, G5, will be affected because if you are able to postpone or even reduce the risk of local recurrence, your survival will definitely improve on a long run. The median follow-up the study so far doesn't allow to make this conclusion, but we all look forward to see what's going to happen in the year to come. And I pretty much believe that this will occur. Of course, in other situations like this, radiotherapy is recommended anyway, should be recommended. Anyway. The tumor about the spine or the spinal foramen, and whatever you believe in terms of radiotherapy or non-radiotherapy administration in the preoperative setting, these are tumors that need always to be considered for radiotherapy. Few words about preoperative chemotherapy, which is not a real topic for today, but I just wanted to leave you with a glance in the future. So a patient like this, 65-year-old female with a large leiomyosarcoma genetic vena cava, the risk of dying is pretty high. So these are patients that are really, really high risk of dying. Should we consider chemotherapy or not? Given the high risk of distant metastasis, is still a matter of discussion. Some people will use chemotherapy, some others will not. In a case like this, we did use chemotherapy, and we observe a wonderful response, which doesn't occur all the time, but in fact, leiomyosarcoma tend to be sensitive to chemotherapy. And so there is an ongoing effort. Basically, there's a study that's just started, which is called STARS 2, where patients, exactly the patients that were not benefiting of preoperative radiotherapy, so high-grade differentiated liposarcoma and leiomyosarcoma, are randomized to either receive neoadjuvant chemotherapy or surgery alone. In order to make this effort effectively, in order to be able to succeed, in order to be able to do studies together, to make advances in knowledge, to make advances in the field, collaboration is critical. We are dealing with rare cancer. This is retroperitoneal sarcomas are even rarer than subtypes sarcoma in general. So we established this group that Bruno was alluding to, this transatlantic Australasian retroperitoneal sarcoma group. This group is a group of people that have a specific interest in retroperitoneal sarcoma, and all Swiss surgical oncologists that have an interest in this are invited to join because the group is very open, and the collaboration so far has produced very many I think, piece of evidence that have helped treating these patients in the recent years. The group spans in very many continents, basically in North America, South America now, Australia, Australasia, and of course Europe. And again, Swiss is invited to join. Having said that, I would like to thank you very much for your attention. I hope I was clear, and I'm really happy to take any questions you like.
Alessandro, you really have to be congratulated for your really nice overview. You packed a lot of information in a very short amount of time. I think it was just excellent. Thanks so much. For the discussion, we might also adopt the same suggestion that you went through. Maybe first we can concentrate on the diagnosis, and then on surgery, and then on adjuvants and collaboration. So considering that we have a really international audience and also pathologists among us, are there any questions regarding establishing the diagnosis? Please feel free and unmute your microphone.
Can I just add one thing about this?
Please.
Do you see questions? Because I don't see the chat. Maybe the people are in the chat.
No. Do you have Sie etwas, Familie Richter? No, there are no questions.
No questions in the chat. No.
Okay.
No, there's nothing for the chat. But any questions right now from the audience regarding diagnosis?
One thing that I can maybe worth to mention is that while preoperative biopsy, the accuracy of preoperative biopsy is pretty high in terms of histology definition. So it's not a problem to establish diagnosis of liposarcoma or leiomyosarcoma or other type of diseases. What may be complicated to define is the exact malignancy grade, because you are dealing with huge masses, and the accuracy of grade definition, for example, liposarcoma, is not as good as the accuracy of the histology definition. So while the histology definition is in the 90–95% range, the accuracy definition of grade is in the 50–60%. Why so? It's because they are heterogeneous masses, and you need to choose the worst looking solid areas if you want to have the proper malignancy grade. This may have implications, especially if you want to separate the management of high-grade differentiated liposarcoma from that of intermediate or low-grade differentiated liposarcoma. So you need to be sure that what you are actually dealing with is, in fact, an intermediate and not a high-grade, and vice versa. So in order to do so, you need to have an experienced team. You need to look at the scans together and decide what to biopsy, not just the mass, but the worst looking areas of the mass. And occasionally you need to use PET scan to see whether there is differences in the solid component in terms of SUV uptake, and decide to biopsy the hottest areas of the tumor.
Interesting. How do you deal with the biopsy tract? Do you use Scott?
No, we don't take it out. So, and by the way, I know that there is this thing that biopsy tract should always be excised in the extremity, and this is a kind of a rule written in stone. So but dealing with soft tissue sarcoma at all sites, as I do, I can tell you that the risk of seeding is really very much histology dependent. So there are some histologies that do, in fact, seed a lot. Chondrosarcoma is an example. Chondrosarcoma, if you mess up chondrosarcomas, it's a disaster. And most of the tumors that have a mixed component, mixed liposarcoma, extrascalar mixed chondrosarcoma, this kind of tumor, mixed of fibrosarcoma, this kind of tumor do tend really to seed if you don't treat them properly. Here, you're not dealing with these histological types. With chordomas, another disease that basically implant everywhere. You have the well-differentiated liposarcoma subgroup. It doesn't behave like that. There's no myxoid component there. I mean, leiomyosarcoma is the same. And so if you use a protected shield, so basically you use a coaxial needle with a protected shield, it's very unlikely that you see a seeding of the biopsy tract, even if you don't take it out.
Very good.
Proven. So we actually have series, hundreds of patients that have been biopsied without any biopsy tract removal because it's impossible to remove it, basically.
Exactly.
And the risk is basically, well, less than 1%.
Very good. Further questions regarding diagnostics? Then let's go to the surgical aspects. Are there any questions? There are many surgeons among us, even from Quebec. Are there any questions from your side? Please now unmute your microphone so that we can hear speaking you. To be honest, I'm a little bit worried that we don't hear anything. Is there a technical problem?
We can unmute everybody if you like.
Yes, please.
I will.
So there are many. Paul, Stefan, Andy, do you hear us?
Bruno, we hear you.
Okay. Good, good. Are there any questions regarding the surgical? I mean, I realized, not being a visceral surgeon, but I realized Alessandro made a very clear statements. And I know that there are different opinions, of course. But of course, Alessandro has a very good reason why he says how he was told us. So are there any questions regarding, let's say, the extended approach versus the limited approach? Okay, so that means that it was quite clear. I think there is really not much to say because you made clear statements and you brought your number, and probably only few people have, let's say, the experience that they can come up with this, with yours. But I think this is really shaping then what you say, and I'm really thankful that you mentioned also this most current data that you are about to present at CTOS. Then you also made in the third part a summary regarding radiation and chemotherapy. Do we want to add first chemotherapy? Is that, or was that also this clear? There are many radiation oncologists around among us.
Can I ask you a question?
Pardon?
I have a question for you, Alessandro.
Yeah.
I'm very impressed by the data when you collect the Strexit and Strass. I never seen this data before. So you mentioned that one third of patients refused to be randomized in the Strass study. For which reason? They want to be operated or they want to receive radiation therapy?
They wanted to be operated. There were a number of reasons why it was, because, this is a large center that included the majority of patients in the study, were treating patients from all over the country, and remaining in Paris, Milan, for 6 weeks is costly. So, if we were, what they were saying to us, if you are sure that this is the therapy, I'm happy to stay, find a way to solve my logistic issues. But if it was for a study, you don't even know whether I need to stay or not to stay. For me, it's a problem to remain, and so I prefer to be operated right away. And then that was what we Milan. So logistics.
And considering the data on liposarcoma of grade 2, when we combine Strexit and Stras, do you recommend it today to your patient to receive?
I'm starting doing radiotherapy to all well-lit and mitigate the deep cycle. I'm doing it.
Okay.
That was going to be my question, Alessandro, as well. How can you recommend radiotherapy when you promoted yourself for a negative randomized clinical trial and you're evaluating the subgroup?
Yeah, but you know, I mean,
no, just pushing, but of course, I tend to agree with you.
The thing is that, well, the randomized, when we started randomized study, we didn't know many of the things we know today, number one. And it's very unlikely that we repeat the study ever again. Because you don't have the resources to do it, you don't have, for me today, you don't even have the resources to repeat it, because there are some signals that are practically clear in the ARFS system. So the same signal that you find in the randomized study are found in the Strexit cohort when you consider it alone. So when you look at the matched analysis, you have exactly the same results that you have in the Stras study. So no difference, some difference in the overall population, which is obtained basically by a larger difference in the subgroup, and which makes sense, no? And then, on top of this, combine the two studies, what you see is an even more convincing benefit local control subgroup, which has the highest risk of recurrence, which is very logical in a way, and goes in the same direction the use of radiotherapy therapies. So you don't come out with a single orthodox answer, but when you put together pieces of evidence that come from different areas, at the end of the day, but you know, in the law,
So
three indexes are approved.
So considering this data on liposarcoma of grade 2, it is the reason why you have excluded in the next Stras 2 trial the liposarcoma grade 2 to maintain only the liposarcoma grade 3 for randomization between chemo versus. Okay.
Yeah. And also because the metastatic risk of grade 2 disease is down, is less than 10%. Is when you have a high risk that it increases to 40%. So since the systemic chemotherapy addresses the systemic risk, if the systemic risk is low, you dilute the risk and you don't see anything.
We have a question here from somebody. What do you think about intraoperative radiation in retroperitoneal sarcomas?
So I expect this question. So IORT is one of the ways to deliver a boost after proper treatment, before a proper treatment. There is no proof ever provided adding intraoperative therapy to external radiotherapy add anything to the control of disease, so to local control. There's no proof at all. So I think it's a nice idea. It should be performed in the context of the study, but given the side effects and the toxicity that intraoperative radiotherapy can add to radiotherapy in general, one should run it in the context of the study to believe in it, but not outside the study, because there's no evidence that we're really able to improve the local control at all. And when you look at what happened in the extremity, even in the extremity, the use of intraoperative or postoperative boost has been abandoned when you perform preoperative. No one does as a anymore after preoperative therapy, even when you have positive margins, to a positive margin in the extremity, where it is much easier compared to the retroperitoneal to perform a boost on a marginal area. So I don't think it should be used routinely. It can be used in study, but not really recommend its use outside that.
Any other comments, questions on this topic? Maybe another question, Alessandro, you showed very nicely that let's say, to remove a sarcoma in the retroperitoneum, there are many surgical skills required from, let's say, different disciplines. So you therefore consequently also mentioned, well, it needs to be a sarcoma surgeon. So that leads to the question to me, how do you define a sarcoma surgeon?
You know, at the end of the day, a sarcoma surgeon is a surgical oncologist, is a fully trained surgical oncologist who has been exposed to major abdominal surgery. He may not be skilled enough for, I don't know, vascular surgery, but there are minor things that can be added when you need them. So minor skills that can be added when you need them. The most important thing is that the surgeon that does retroperitoneal sarcoma is able to perform major GI and it's able to biliary surgery, because these are the two things that he may need the most. So then he may ask a urologist to come into the team, or definitely not a gynecologist, but or a vascular surgeon to join the team when he needs him. But the most skills, the skills required most often are just GI and epitobiliary. And of course, orthopedics, because we do a lot of orthopedics. I learned a lot from orthopedic surgeons, very much. And I did operate a lot with spine surgeon in Italy. He is really good. So sometimes
very nice. So what's the value of, let's say, numbers? I mean, regulations go more and more in the direction that they define numbers because that's the easiest.
It's the easiest way, yeah. Yeah. Well, probably there is a question in the chat. We are asked how do we handle the motor loss resulting from resection of the lumbar roots or psoas resection. So when you resect the psoas, you don't. I want just to make it very clear. You don't resect the femoral nerve. You don't resect the lumbar, because the lumbar roots and the femoral nerve lie behind the psoas, so you can preserve it. And a resection of the psoas doesn't result in any real motor loss. You have a weakening, of course, the flexion of the thigh of the pelvis, but it's just a weakening because you maintain the iliac muscle and then you maintain the adductor muscle, so the gluteus and so on. So basically the walking, the gait remains unaffected. And even if the patient is not a professional runner or a professional jumper, he doesn't really realize that the psoas muscle is not there anymore. I always show to the fellow that come here from other countries that are interested to see how patient behave without the psoas, that the patient who walks in our office without the psoas basically doesn't even realize not to have it. So we have, so it's not a matter of muscle, it's definitely a matter of nerve roots. So, but nerve roots can be preserved easily if you know where they are, of course. And there's no need to resect them unless they are really embedded. In terms of numbers, so your question, Bruno, well, there have been a lot of efforts to establish a minimum number of cases for a sentence to be considered a reference sentence, and all these numbers are not yet backed up by any real and strong data. In the US, they are trying to establish this by using the NCDB, so the National Cancer Database. But in the National Cancer Database, there are no centers doing more than 15, 20 cases per year, while in Europe there are. And whether there is where is the plateau, the threshold, over which there is no further improvement in terms of better outcome, is still a matter of debate. And we will probably be trying to look at this, because we have established an international registry which has now collected over 1,600 cases in different countries and different areas of the world, where the case volume vary broadly. So we may be able to see whether it does make a difference, where is the threshold. Personally, I believe that this is somewhere between the 20 and 25 per year, primary cases per year, because this allows you to be exposed enough to the variability of the disease, But I understand that this may mean different things in different countries because there are different populations that you also need to take into consideration that may, in a way, have an impact in the definition of what is the threshold. But yet, besides logistics and geographic variation, I think it would be nice to have a threshold. Because this may well mean that in Switzerland, for example, you don't need other than one center, all the countries should send it there. I know this would be difficult, but if you have, evidence to prove that this is the way to go on, at least you can back up your lobbying, your political lobbying to have this done. Especially in the red, because this is basically 10% of sarcomas means 0.1% of all cancers. You're not basically stinging a lot to other percent.
Yes, yes. Well, thanks so much. One last call for questions. Then let's say having all this and Alessandro and Jean-Yves and Axel with us, any further remarks from your side constituting the international board of the SSN?
I have a question for Axel. Axel, is he around or not?
Yeah,
He's here.
Axel, are you using radiotherapy now or you're not?
Not yet.
You are not.
In some relapse case, we discuss radiation therapy first.
So
but
don't recommend radiotherapy anymore.
yeah, I recommend. It's just a last question. I saw in the histological types you describe in the TRUST in your presentation. You mentioned Leio, Lipo, MPNST, UPS, and SFT. And there is another group of 26 other. Which are the other histological subtypes in this retroperitoneal area?
Well, you have these synovial you have that originate in the retroperitoneal, from the kidney, sometimes visceral, but it's located. You have pecomas. Not included. You have some
clear cell sarcoma of the gut.
Yeah, clear. No, in the gut is not included. It's not included. They are predominantly few, but they exist. And yeah, more or less.
Axel, you wanted to ask something too?
No. It was my last question.
Okay. Jean-Yves, any concluding remarks from your side?
No, maybe I think we are all left with exactly what Alessandro said, with making recommendation despite the limitation in methodology. Now, the question I have for the chemotherapy study which is going to start anytime soon, which has started actually, is what's going to be the role of radiotherapy in this context?
It's only dedicated for grade 3 liposarcoma and Leio, so there's no overlap.
Now, there's no overlap, and I believe that, this study, actually the study, even if it's highly underpowered for high-grade differentiated liposarcoma, honestly, it's not super powered. It goes in the direction that we believe it. The truth is, so we will not be using radiotherapy in the study. The patient who will enter in the study will be chemotherapy.
Okay.
Okay. Well, thank you very much. It was a great pleasure to listen to you, Alessandro. Again, many thanks for this great effort and also for this lively discussion.